Hello, can you guys hear me?
Yep, we can hear you. Thanks, Corinne. Very kind of you to be available again. Thank you so much.
My pleasure.
So I think it's all started without us, didn't it? It nearly started without us.
Yeah. Yeah. Is Alison there?
Yes,
Yes, I'm here. Hello.
Okay. I'll introduce you, Alison.
Perfect.
And then Steve is going to be thanking you at the end. You don't mind if we chip in the course of
Please
this?
do.
Okay. And let's see, yeah. We're not having any videos or anything, are we, from Astellas?
No.
Or reps or anything from Astellas, are we, Corin?
No.
Okay, Corin. Where are we now?
Yeah, so I think we can fire away. I mean, that's
But what is the time?
It's 5 o'clock.
Oh, okay.
So it's time to start. And
Okay.
yeah, we can just introduce Alison, who's very well known to us and a very good friend of ours. But yeah, maybe you can do a formal introduction.
I will.
Yeah,
Are we on song?
I think
We
we're
are
not
indeed.
on yet.
And you're not doing the music today.
Oh, we're not
Peter.
doing
Go
music.
straight in, yeah.
Okay.
We did do the music just before you connected, so it's all sorted. We are ready to rock and roll.
Good afternoon, ladies and gentlemen. My name is Peter de Jong, and we have with us here Professor Steve Jeffrey. It's a great honor to have also Dr. Alison Moore. Professor Steve Jeffrey is a urogynecologist of note in Cape Town. In fact, I note him as one of the 10 best urogynecologists in Cape Town. And he's going to be with us this afternoon when we have Dr. Alison Moore, who is no stranger to this platform. She's presented several times before, and she graduated as a fellow of the College of Urologists in 2020. So she is a qualified urologist, fellow of the college. What is the woman for fellow, Steve? Fellow, if you're a fellow, isn't there?
Fellow's more sort of how should we say
Fellow.
Gender neutral.
Oh, it's a gender neutral.
No,
okay.
I think that's how we're seeing it now. I think that's
All right.
that's the right terminology.
Is that the right terminology, Alison? You don't mind being
From what I understand, yes, that's what we are, yes.
good fellow is just
Good
one
fellow.
of the, you don't mind if we call you a good fellow or maybe even a dude? No.
More
Okay.
than happy with all of
And
it.
are a urologist from 2020, but more importantly, you're completing your subspecialist training. And I see Alison, as you know, every week at the University of Cape Town's Clinic for Continence, and we certainly do have a good relationship. And she then, at the end of September, will be doing your oral for completion of the fellowship in urogynecology. So this will be the first woman, no, the first person, the first urologist in South Africa to complete accredited urogynecology fellowship, Steve. So without further waste of time, I'd like to thank Astellas for sponsoring cystoscopy and its importance to the general gynecologist. And as importantly, next week we have a case-based study talk on IUD contraception presented by Dr. Julie Kluge and sponsored by Bayer. So, Alison, it gives me great pleasure to have you on the platform this afternoon speaking about cystoscopy. And I spoke yesterday to Alison, we're going to have a feast of pictures, and this atlas, if you like, of cystoscopy is something of great importance because I often see things in the bladder. I have no idea what I'm looking at. Half the time it's the air bubble I'm trying to biopsy. So without further waste of time, Alison, cystoscopy and its importance to the general gynecologist.
Good.
Fantastic. Thank you. I'm going to just share my screen quickly and make
I mean, well done, Pete. I mean, you're one of the gynecologists who, in fact, does cystoscopy. So, I mean, that's immediately a win.
immediately.
Yeah. So, I mean, that's the fact that you maybe aren't understanding what's going on there.
Maybe not. I don't know what I'm seeing, but the important thing is I'm looking.
Yeah, but I think that's
If there was a massive hole in the bladder, you'd probably spot it. So that's all good.
If there was a massive hole in the bladder, I'm the guy that made it.
Well, we all make holes in the bladder, Pete. So, you know, we have to accept that. Is my slide showing okay? You can see things and there's no presenter notes or anything. Good. All right. So thank you for the very kind introduction, Steve and Pete. It's lovely to be here with you all again this evening. I hope that you'll all feel that you can ask questions on this topic if there's anything that's not clear. And I'm going to get going on a cystoscopy and why a gynecologist might find that it's an important part of their routine knowledge, skill, and their practice, and where we might use it. So, cystourethropy, I suppose, would be the full formal term, where you're imaging both the urethra and the bladder, in that the urethra is the way to the bladder. You can also evaluate the upper urinary tract, so the ureters and the kidneys, with a cystoscopy by doing a ureteric catheter insertion into the ureteric orifices, and you can put contrast medium into there. So if you put contrast into the kidneys, you can also assess the anatomy and for any filling defects, or importantly for us as gynaes and urogynaes and urologists, is whether we've caused ureteric injuries, for example. So as Pete had mentioned, air bubbles are a common thing that we see on cystoscopy, and this right-hand picture here is then an air bubble that's at the top of the bladder. So you'll have them float to the dome, really. So that's a normal finding, and it's good to just know that that's what you're seeing. So just a bit of a history about endoscopy. Well, humans and people have been trying to look in our bodies with scopes for as long as we've all existed, but it was a urologist that developed and termed the initial endoscope phrase, or the term endoscope. He's a French urologist, Dr. Desimau, and the first modern endoscope really wasn't developed by him, but it was another doctor who developed this big conductor, a huge machine really, with aluminium tubing attached to it. So you couldn't use that in the bladder or the uterus at all, but there were mirrors that were angled to conduct light from a candle into the body. And it was Desimau that then made this smaller, so that we could then actually look in the bladder. And he used a kerosene lamp for illumination. And there was eventually then in 1877 or something like that, eventually when Thomas Edison developed a light bulb, that they then incorporated light as in terms of electronic light into endoscopy. So what do we need to do a scope? So on the pictures on the top image, this is a urethroscope. So that's typically the view that you get when you put Bulkamid into the bladder neck for stress incontinence. So that's a 0-degree lens, which is looking straight ahead, and it's fantastic for visualizing the urethra. But otherwise, generally we use a combination of 3 different components when we do a standard cystoscopy, which is that you've got your optical lens or a telescope, which can be usually a 70-degree or a 30-degree, but the 30-degree is probably the one we use most often to do biopsies or to assess the trigone and the bladder. But if you're looking for more detail of the anterior bladder and the bladder neck, such as when you're doing a sling, for example, and you want to make sure you haven't caused a bladder injury, then you'll be using your 70-degree lens. Your bridge is the connector, and that connector will have a possibility of having working channels that you can put instruments in and perform biopsies or laser or coagulate any bleeders. And then you've got your sheath. Gynecologists will obviously be highly proficient in performing hysteroscopy. So a lot of this is very standard, and a lot of it is similar to hysteroscopy. But it's I think specific to urology that you've got this benefit from a variety of degrees of vision with the different tips, and then the bridge specifically, can be adapted for doing various instrumentation. So why would we do a cystoscopy? So, I mean, there's these indications, some of it will overlap with why urologists would do cystoscopies, but the most common indication worldwide for doing a cystoscopy would be if somebody had visible hematuria or persistent non-visible or microscopic hematuria. So I think that as gynecologists, an enormous amount of the patients the postmenopausal patients especially will have microscopic hematuria, which may persist, and certainly genitourinary syndrome of menopause with atrophy or severe atrophy can cause persistent microhematuria. But it is important to just have that as an awareness and something that one would do, or you would discuss with a urology colleague if you thought a patient had visible hematuria episodes. Otherwise, in the realm of gynecology and urology, we see women commonly who have recurrent urinary tract infections, various storage symptoms related to urination, whether it's frequency, urgency, or nocturia. Many women will describe obstructive voiding symptoms where they've got straining or difficulty emptying the bladder. A lot of patients with chronic pelvic pain, and of course that overlaps with a whole bunch of gynecological conditions such as endometriosis and various adnexal pathologies. So in the workup of chronic pelvic pain, cystoscopy is certainly really beneficial. And then an enormous amount of patients, unfortunately, that suffer urinary incontinence. But I will, in my presentation, start by looking at where a gynecologist may choose to do a routine post-operative cystoscopy. So that's to assess bladder integrity after your procedure, that you haven't had an injury sustained, and how you might assess ureteric patency and sleep better at night and be fairly happy that your patient's not going to have urological complications of their gynecological surgery. And then I think in our current climate and generally, I think we all need to be more aware of just taking a brief history of whether our gynecological patients have had mesh procedures, because I think there's a ample space for litigation and complications in this field. So, the patient who's got chronic pain has had mesh before, has incontinence and has had mesh before. Those patients, you really probably do want to get a cystoscopy at some point to make sure you're not missing complications of their mesh. And then the therapeutic procedures really is where the urologists often work, but a lot of urogynecologists and perhaps some of the colleagues who are doing frequent cystoscopy, such as colleagues that work in endometriosis, may end up doing bladder biopsies because that's something they become very confident with or familiar with. But management of stones is often something that the urologist really ends up doing, and things like urethral strictures are certainly something that you might bump into accidentally. But the treatment of that is certainly not something that gynecologists are expected to do, and not something that you're necessarily trained in either. But all of these things are of issues one might bump into. So let's discuss gynecological surgeries that are associated with urinary tract injuries. So as gynecologists, one works right next to the bladder, and it is very difficult in a long successful career as a gynecologist to avoid never having a urological injury sustained. This is part of complicated surgery and sometimes part of an uncomplicated surgery. So of all ureteric injuries that occur in any field, unfortunately gynecological surgeries end up causing the majority, and it's the proximity and it's the way things are. But urologists certainly cause ureteric injuries, as do colorectal surgeons. And it's hysterectomy, Caesars, prolapse surgery, and stress incontinence surgeries that often are worth thinking about. But there'll be significant oncological surgeries where you've got radical hysterectomies. There'll be adnexectomies and large adnexal masses that will also potentially have ureteric injuries identified. So then we'll go into hysterectomy on the next slide, but with Caesar, we're really not looking at using cystoscopy at the time of Caesar. You've got an open abdomen. If you're worried about a bladder injury, putting methylene blue in will help you to identify that. It's often the missed ureteric injury during a more complicated Caesar or Caesar with significant bleeding that we end up then, as a delayed stage. There's sometimes ureteric injuries that are found, and you'll go for the cystoscopy at a later point. Prolapse surgery, there's no set rules. There's variations, and different surgeons do different things. Many surgeons that I know and many surgeons worldwide that perform sacrocolpopexy, for example, they do routinely do cystoscopies, but there's an enormous amount of robotic surgeons doing sacrocolpopexies who are not doing cystoscopies anymore. And vaginal prolapse surgery, certainly in my training, has not been an indication for routine cystoscopy at the end, but many people will, after a more difficult anterior repair or you know, a more difficult procedure, consider doing cystoscopy.
Alison?
Steve, please, yes.
Alison, you said just now that if you're worried, you can do installation of methylene blue. Do you mean intravenous injection of methylene blue?
No, into the catheter. Apologies for not making that clear.
Oh, okay.
Yeah.
Into the catheter. Okay.
Yeah.
And if you don't have any methylene blue available, what else could you put into the catheter? Anything else?
I mean, you could certainly just, if you've got a fairly dry field, you could certainly just put normal, saline in and see if you can identify, a fluid dribbling out of the, whether you expect you might be concerned.
Okay. Methylene blue or saline. Okay.
Yeah, it's not too difficult to see if you use saline, and we do that quite regularly as well. On the point of not doing a cystoscopy at prolapse surgery, I don't think that's really a good idea at all, Alison. I don't know, who's practicing like that. And even with sacrocolpopexy, I've done sacrocolpopexy where I've seen a suture in the bladder inadvertently. So, and you and I both know it literally takes about 3 minutes to do a proper quick cystoscopy after a procedure while someone's closing the ports. So I don't know why the robotic surgeons aren't doing the cystoscopies either when they do sacrocolpopexy. But I mean, there's so much to gain and so little to lose. So I mean, I just I don't know. I don't understand why people aren't doing it, to be honest.
I'm not sure why either. I mean, when I started my training in urogyne, I would feel most comfortable just doing a cystoscopy on everybody. And I always go back to a case in my early training when I was doing an anterior repair for quite a big cystocele, and I was plicating, and my bladder neck plication, I placed the suture and I did the cystoscopy at the end because everything looked okay, and I had kinked the ureter with one of my plication sutures at the bladder neck. So I hadn't got the suture around it, but there was a medial deviation of the ureter. When I did a retrograde, you could see that there was a bit of a kinks, and as soon as I removed that one plication suture, it all was fine. So I think there probably are a lot of sort of urological changes that are happening and people are not picking them up, and maybe years later people are having some chronic hydronephrosis. Who knows? We don't know, because from my reading at least, vaginal hysterectomy, anterior repair, it's not at all mentioned that one should routinely be doing a cystoscopy for those.
Look, Alison, in the end of the day, I think common sense prevails, and
I agree.
To be frank with you, I would say you're heading towards sort of litigation if it's not something you practice routinely. So I'd say I as a person who does a lot of this kind of surgery, routine cystoscopy after every surgery I do nearly. I mean, especially laparoscopic hysterectomy, you never know what you're going to find. I mean, you can come quite close to the bladder when you close the vault. And for any urogynecological surgery to not do a cystoscopy, I would wager that's potentially negligent. I think it would be very difficult to defend in court if found to have a fistula after an anterior repair or anything like that. Probably not a posterior repair, that's maybe, but I still do it after posterior repair for some reason. So, but I mean, Pete, what do you think?
No, I absolutely agree with you, Steve. And whenever I work with Steve, he leaves me, he goes off to drink coffee, and I'm the guy left to do the cystoscopy.
Exactly.
So it's important to do it as a routine. It's not an issue, and we mustn't make it an issue. Let's just do it.
I agree with you.
Yeah, no, I agree. I don't know why. I don't know if it's that the robotic proctors that I've kind of had kind of anecdotal discussions I've seen people do robotic surgeries and not do the cystoscopy, and I just haven't they have said they feel if they're not concerned that they haven't done it. So it's just something I've noticed, and I don't know why the trend is going that way. But then it's also, I think, really important for us to be routine with doing your cystoscopies when you're doing stress incontinence surgeries. I mean, that's something we obviously all should be doing. And I think, you know, there's this feeling that the transobturated TVT, for example, has much lower chances of causing urinary tract injury, but urethral injuries and transection of the urethra with mesh has certainly been seen following TVTO. So I also think it really should just be a routine that if you're doing a stress incontinence procedure, a cystoscopy at the end should be something that one includes. So with hysterectomy, bladder injuries are much more common with your abdominal hysterectomies than with vaginal hysterectomies, and the kind of overall percentage rates in various studies and kind of big meta-analyses are mentioned there. And ureteric injury rates also have been not insignificant. And most of the time, if you're going to have a fistula develop after a hyst, it's more likely that it'll be bladder related than ureter injury. But one always wants to make sure that you exclude ureter if you've got a fistula that develops after any hysterectomy. But yeah, I do think that as a result of these percentages following hysterectomy, and especially our laparoscopic hysterectomies, I think all colleagues are doing routine, or should be doing routine cystoscopies after hysterectomy. And I'll go into ureteric assessments and kind of assessment of patency in the next few slides. So we've got ureteric jets that we can use. We've got ureteric stenting that we can consider. And then methylene blue and other kind of intravenous dyes, really, we're not using those very often. I certainly find that a lot of the hospitals, you just don't have access to the intravenous products. And I don't think there's necessarily a need for it if you're going to be able to use a ureteric stent and put contrast medium up and assess your ureters with fluoroscopy. So in terms of ureteric jets, there's a lot of kind of controversy in some of the old literature. So the textbooks I was reading when I was a registrar in urology, there was a couple of studies that were saying that ureteric jets are not reliable, that the absence of ureteric jets, for example, doesn't mean you have an injury. So you wouldn't, proceed straight to opening up your abdomen. If you don't see ureteric jet, you should maybe proceed with putting a ureteric stent in or something, a catheter to assess further. But the presence of ureteric jets, whether if there's a partial injury or a partial obstruction of the ureter, that certainly would still be present. And of course, the thing that's otherwise challenging with ureter is that if you devascularize your ureter, for example, during some of the hysterectomy dissections, you can end up developing delayed stricturing, which is a whole different issue that you won't pick up at your acute cystoscopy and ureter evaluation. So, what techniques can you use? What's going to help you? So the images that I've got here, the bottom right image, this is just demonstrating what I was speaking about now, which is the delayed stricture that one develops if you've devascularized the ureter. So that's narrowing and scarring of a significant, more than 2 or 3 centimeter portion of the ureter. And then this image at the top, that's ureteric kind of partial tie-off at the time of Caesar. So this was a delayed presentation of a ureteric tie-off or injury during Caesarean section. So what are we going to be doing? How are we going to assess? What are we going to use? How are we going to improve the chances of seeing jets? You don't want your bladder to be over distended. If you've got an incredibly full, 400 ml bladder, you're going to increase pressure. You're going to potentially close off that Walde's sheath, which is the intracycle or the intramural aspect of your ureter, and you won't necessarily see jets, and the bladder pressure will be potentially too high in any case. So, really 100 or 200 mils of fluid in the bladder should be more than enough to be able to see and then allow your jets to be there. Is the patient adequately hydrated? If you've had significant blood loss, you've had a patient who's had poor urine output during the procedure, you may struggle to see ureteric jets and can take quite a few minutes, more than 2 or 3 minutes, even up to 10 minutes before you see anything. You can also see the ureter retracting or peristalsing, but it doesn't mean that they're not transected. So you actually do need to see fluid ejecting out of the ureteric orifice rather than just seeing the ureteric meatus or orifice itself moving or retracting, because that can still happen even if the ureter is transected or tied off. And then, as I've mentioned, you're doing a ureteric catheter passage, and putting a retrograde contrast in will be the thing that will be able to confirm whether you've got narrowing, distortion, or some sort of injury or leak of the ureter. And then just on this topic, so it's not necessarily just the findings with cystoscopy, but what do we do about, how to prevent these injuries? So pre-operative ureteric stenting, so you place a stent because you think you have a higher chance of developing an injury or you've got a huge mass. So there's no evidence that this reduces injury, but what it does help is it helps you to pick up that you've had an injury during the surgery, which is, of course, what you want. You don't want to have the delayed pickup and the missed injury. Unfortunately, placing ureteric stents before you proceed with your abdominal surgery does not have no complications associated with. You can have bleeding and hematuria, urinary tract infection. You could certainly get ureteric perforation or major injuries, but that's a very low risk. But the current recommendations are not to put ureteric stents in for all patients who are going to be undergoing pelvic surgeries, but it's something that you need to do a risk-benefit discussion about. So then mesh complications.
Alison, sorry, on that point, I certainly find them very useful in a lot of patients. I think once you get into that complex patient who's maybe got a lot of adhesions, previous surgery, previous sacrocolpopexy, whatever it is, and you've actually digging around the whole time around the ureter, to actually have that stent in place, it really does, that has great benefits. So I think it was always hard to take evidence and transpose it directly into practice. So
yeah.
And I think if you think about a stent in a patient, you might actually indeed want to use one. And as you know, it's easy to place. I do find them very useful in a lot of patients. And I will often put them in intraoperatively if I'm really struggling to find the ureter, or if I know I'm going to be working quite close to it. So and as you know, I mean, they're quite easy, don't you think? It's not a difficult thing.
Yeah, I think they're fairly easy. But one of the things, if you're really struggling, so like if the patient has a big cystocele, for example, and the whole trigone is quite descended and you're struggling with angles, then what one can do is you can you can ask an assistant, or you yourself can put a finger into the vagina, and you can actually just lift up the trigone to help to see the ureteric orifice, and that can help you to sometimes just get into a position that gets the ureteric stent or the ureteric catheter in more easily. Yeah. Good. So mesh complications. So the images that I've got here, the top image, this is of mesh transecting the urethra. So there's been a missed urethral injury, and the mesh is kind of ingrown into the urethral wall, and that will certainly cause a lot of dysuria, pain, some hematuria potentially. And then the image below is a mesh that has been placed through the bladder, and there's stone incrustation that's formed on top of that mesh. So mesh injuries of the urogenital system are not unheard of, and that's why we really should be doing cystoscopies with all patients that we're using mesh in the pelvis for. And then I think if you have had a patient have chronic pelvic pain, urinary frequency, urgency, and they've ever had mesh before for prolapse of any sorts or for incontinence of any sorts, I do think it's prudent to do a cystoscopy in that patient to make sure you're not missing a mesh complication. So that's my section on urological injuries related to gynecological surgeries. And now what I'm going to go into is incidental findings, or things that you may find if you're doing a cystoscopy to work up a lady who's got irritative void storage symptoms, and kind of what are the commoner urological pathologies that one might do if you're frequently doing cystoscopies, and even things that are maybe asymptomatic for patients. So we'll talk about bladder stones, patients. We'll talk about urothelial cancers. And then I'm not going to go into radiation cystitis and TB because they're really not very common, and the history would potentially be there, but I thought I would just mention it because they are worth keeping in the back of one's mind. But radiation cystitis, you really should have a classic history that the patient has undergone a pelvic radiation before, and the patient normally has pain and quite severe urinary frequency urgency, and they've got a small bladder with this pale mucosa of the bladder with petechial bleeding or kind of telangiectasia changes. But it's quite classic, and they can get quite severe hematuria. So it's not often that you'll have a patient that's, you have an incidental finding of radiation cystitis. And similarly with TB of the bladder, if you develop tuberculosis of the bladder, you're going to have really severe symptoms. The TB of the bladder normally ends up causing quite severe dysuria and scarring and fibrosis of the bladder, and you end up with a very small capacity bladder with kind of these scarring, pale areas. You get these golf hole ureters where the ureteric orifice becomes massively dilated from chronic scarring. So those are not really things that you'll incidentally pick up. And I think it's, I in my kind of practice haven't ever kind of done a scope and incidentally picked up any of these issues. The one thing that I will say with TB though is that it's one of the causes of persistent sterile pyuria. So if a patient has persistent leukocytes on dipsticks, or you send microscopy away and you do routine culture and there's no growth but there's persistent leukocytes, then that's one of the causes. And I mean, TB is a significant issue in the Western Cape. So bladder cancer, these are the various kind of stages or the presentations, but I'll be talking about the things that we might pick up in early stages, because if you've got more advanced stage T3, T4 cancers, those patients are going to have significant pain and significant gross or frank hematuria. So your early stage bladder cancers are the things that you might actually incidentally pick up if you're doing a cystoscopy at the end of a kind of routine gynecological surgery. So carcinoma in situ will go into, and your kind of superficial low-grade cancers. So low-grade transitional cell carcinoma of the bladder or urothelial cancer, they appear to often be like these kind of pretty pink coral shaped looking little lesions. They're papillary. They can have kind of slightly more kind of clustered looking, but in the early stages they tend to look like these pretty pink little balls. Smoking is obviously the major risk factor for the development of any bladder cancer. Now these urothelial cancers can be there for a really long time before they cause any symptoms. You won't necessarily present with microscopic or macroscopic hematuria. Well, microscopic, yes, but you won't necessarily have visible hematuria. So these could be picked up incidentally. And the prognosis for the patient really depends on how big they are and how many there are. But if you see something like this on a routine scope, you won't have consented the patient for a resection. So a complete resection is not what you'll do, but a biopsy, of course, would be really helpful. Or if a urologist is around, perhaps they can then counsel the patient and arrange that as a subsequent procedure. Carcinoma in situ. So this image might not show up really well, but we've got these flat velvety red lesions. So it can be really tricky to pick some of these things up on routine cystoscopy, but if we want, we can always go back and show those normal bladder pictures that were at the start of the presentation, but this is just much redder and pinker than it should be. You should have these perhaps normal blood vessels, but in between the blood vessels, it's much more of a kind of light pink or pale color, not this angry red color all over the place. The carcinoma in situ of the bladder, which is also a urothelial cancer, is actually a very high-grade disease. It's aggressive. It can progress fast. It can become muscle invasive, and it can kill patients. So this is a really important thing to identify. The patients usually will have some urinary urgency or frequency symptoms. So it means a patient who comes to you with overactive bladder symptoms could potentially have carcinoma in situ. They don't all have macroscopic hematuria at all, but they should have some microscopic hematuria. So that's an important thing to pick up. Bladder stones. So these are not uncommon, and I've seen it's very rare. From what I've heard from Lisa Kestner, who's certainly my source of a lot of information when it comes to urology and urogyny. But with prolapse, if you've got quite severe grade 3 cystoscopy, you can get obstructive symptoms and you can get incomplete emptying. And I have seen a lady who had quite a large cystoscopy and or an anterior prolapse, and she had a bladder stone. So it's not unheard of to develop bladder stones as a result of prolapse and incomplete emptying. But bladder stones can also migrate from the kidneys, and they can also be idiopathic, and you don't identify a specific reason why that patient has made a stone. And then we laser them, or we can just basket them if they're really small, or you can use a stone punch, which is quite an aggressive device that can cause holes in the bladder. But those are used for big stones, and we hopefully don't ever get to the point that you have to actually take a patient for a cystostomy and do a kind of a fan and steel incision. But that has happened quite a few times in the state sector, where patients unfortunately sometimes have many years of suffering with pain before they get help. So we need to investigate these patients to make sure there's not a neuropathic bladder or some other cause for them developing a stone. Bladder pain syndrome or interstitial cystitis. So interstitial cystitis is the appropriate term to use for a patient who has been assessed to have symptoms in keeping with bladder pain syndrome, but then has classic cystoscopic findings in keeping with bladder pain syndrome, and specifically the Hana lesion. So this image on the top here, there's a scar that one can appreciate here. So the scar normally has a pale white center, and there's like a stellate appearance. So there's this very red erythematous surrounding area. So this scar is pathognomonic. It's the classic lesion that you see in interstitial cystitis. And if you hydrodistend these bladders and you fill them under anesthesia, because it's extremely painful to fill a bladder in a patient with bladder pain syndrome if they're not under anesthesia, but you fill them, and on emptying you'll see that the scar bleeds and you get these classic waterfall hemorrhage or petechial hemorrhages. And then with the hydrodistension, the other finding that you can get is these small glomerulations, which are these small petechial hemorrhages. So these little petechial hemorrhages are not pathognomonic for bladder pain syndrome, but in a patient with classic symptoms, this is a suggestive cystoscopic finding. So like I'd mentioned at the beginning, all patients with chronic pain and really who is struggling to identify a cause of chronic pelvic pain, a cystoscopy is a relevant investigation. So I'm going to go a bit into chronic cystitis. So recurrent UTIs are incredibly common, and postmenopausal women have a lot of recurrent UTIs. Squamous metaplasia is not associated with chronic cystitis, but it's an incredibly common condition. It occurs at the trigone, and it's this flat, pale white chain. It's incredibly common. You'll see it in a lot of cystoscopies. There's no need to do anything about this condition. It's not something that's has a malignant potential. It can be associated with patients that have incomplete emptying, and it's just a cellular change of the urothelium to squamous epithelium, but no fulguration, no resection. You don't need a biopsy if it's very classic and you're quite confident that that's what you're seeing. And most patients will be asymptomatic.
Alison?
Yes.
Alison? Yeah, yes. We all see that. Do you know what actually causes that squamous metaplasia? Is there no etiological pointer that can make us focus on why they occur?
So my understanding is that it is an irritant. So they say it's not chronic cystitis. So it's not a patient who's got chronic inflammation as a result of repeated bacterial infections. But my understanding is that it's a kind of like a protective cellular change. So whether it's that it's kind of the kind of low estrogenic states, because I do think that you've got estrogen receptors at your trigone and at your urothelium at your trigone. So I had read about the fact that it's kind of really a postmenopausal change, and whether it's something that's associated with low estrogenic states and the changes that generally occur, cellular changes. But my understanding from my reading initially in Reg Time, at least, was that it's a response to generally kind of incomplete bladder emptying and a bit of sedative or sumping of urine at the trigone. But it's not a bacterial origin, at least.
Thank you.
That's my understanding, but I'm more than happy to discuss if somebody else has any other understanding about that. So then this is cystitis cystica et glandularis. So this is a chronic cystitis pathology. It is a spectrum of diseases. So you can get these cystic lesions, so they look like these raised bumps throughout the trigone, and that's classically called trigonitis, but it can be all over the bladder wall, and then they call that a pancystitis usually. There can be E. coli or other uropathogenic bacteria that actually live in these cysts, so they can be a source of chronic UTI. So I haven't ever really done this, not in my training at Cystoscopy ever really, but I'd be interested to see how much I see when I'm maybe doing more cystoscopies in private. But it is described and recommended that you should fulgurate these in patients who are having recurrent UTIs, and that the frequency of UTIs seems to reduce in patients who do have these fulgurated, but they can recur. They can get little pus collections. They call them like these pus cells or pus cysts. So they can be larger and have pus in them. And they don't tend to become cancerous, so that they always thought that this was potentially a pre-malignant or a risk for developing bladder malignancy, but there isn't actually a suggested causal relationship. But they can be seen concurrent with bladder cancer. So there are cases of patients having cystitis cystica and also having a cancer at the same time, but they don't seem to necessarily need. So if you've fulgurated them and the patient's recurrent UTIs or symptoms have gone away, they don't need surveillance every year for the rest of their lives. So regarded as quite a chronic or a common condition. Unfortunately, so far in my training, my time at Cystoscopy, we don't routinely do cystoscopies on all of our patients that we're seeing with recurrent UTIs. And if we are doing them, many of them have acute cystitis changes, which is more the red, angry, inflamed bladder. And whether or not those patients may on a subsequent cystoscopy end up having cystitis cystica changes, we don't know. They don't unfortunately get follow-up scopes done. So the histology is that the lamina propria gets infiltrated with cysts on histology, and there's these von Brunn's nests, which also are cystic changes that you get in the lamina propria. I did have a radiation cystitis picture. I apologize, but it's not a very nice one. So pale mucosa is the classic thing. And then telangiectasia, so you get a neovascularization, so much larger blood vessels and very pale mucosa. That's the classic radiation cystitis changes. So I mentioned the fact that some of these lesions are really difficult to see. So I've just put in a slide about newer technologies. There are all sorts of things that are accessible, that you can fill the bladder with various media that can try and improve you seeing things. It's often things that maybe urologists might use if they're surveilling a patient who's had cancer before and they're doing scopes to check if things come back. But narrowband imaging is something that many of the stacks in the good hospitals will actually have. So you can switch to that as one of your options on the view for your stack. And narrowband imaging only uses blue and green wavelengths of light, and these are much more strongly absorbed by hemoglobin. So you've got much improved visibility, and your carcinoma in situ, which is that flat velvety red lesion, it's much easier to identify that, which I think is really helpful. So if you've got uncertainty or you're not sure if this is something that's potentially abnormal, but any blood vessels may also appear more visible because of the hemoglobin within them. So capillaries of the bladder may also be more prominent. So then my last slide is just how to care for patients and prepare for cystoscopies, and what do we do and not do. So just important little things that I try not to forget. If your patient has got a current UTI or recent cystitis or an acute UTI, you don't want to be proceeding with a cystoscopy in them, because you really can potentially get pyelonephritis and septic complications if you perform a cystoscopy in the setting of an acute UTI. And then I think, we fortunately, if we as surgeons are going to theatre, we will have asked the patient if they're on anticoagulation. And it's not necessarily aspirin daily that we're worried about here. It's your patients on dual platelet therapy or warfarin or rivaroxaban or things like that, that you really don't want to take a biopsy in those patients. But you can do a cystoscopy because the aim is that you're not going to breach the mucosa. So if you use a really small sheath, such as a 19 French or 17 French if you have access, but a lot of the time a 19 French rigid scope should be available in theatre. So you can proceed with a very gentle scope, and as long as you're not biopsying, that's okay. If a patient, for example, is coming to theatre for a scope only and they're high risk for stopping their anticoagulation, and you just need to try and get a diagnosis. If you're going to breach the mucosa, the recommendation is that you should give a gram-negative cover. Gentamicin is usually what we use for patients having cystoscopies. And for me, even if I don't end up doing a biopsy and I'm taking a patient to theatre for a scope, or I do a flexible scope in my rooms, I give a prophylactic antibiotic for all of them. But that's for my comfort. But the American Urology Association, for example, their guidelines say that if you're doing a scope and you're not biopsying or breaching the mucosa, that you don't have to give prophylaxis. But that's not how I've chosen to do my practice. So take-home messages. Routine post-op cystoscopies, so your lap hysterectomy, your sacral colpopexy, I would suggest doing that. I think it's as Prof. Jeffrey, as Steve had said, it's a quick step. You won't regret doing it. You will have huge regret if you miss a significant injury, a ureter, a bladder injury, a fistula that the patient presents with at a later stage. In the setting of pelvic mesh in the current day and age, I think it's important to consider doing a cystoscopy with kind of low threshold to doing a cystoscopy on patients that have vague symptomatology in the pelvis and have ever had mesh put in. And there are many bladder pathologies one can identify on cystoscopy. It's a really helpful tool. And I think we've hopefully got quite a few friendly urologists at many of the hospitals. So call a friend if you're unsure. And in this day and age, we can send photos, which is also really helpful. So that's my messages. And I'm more than happy to take any questions.
Can I just quickly start with one question from Habib M. Habib? He wishes to remain anonymous. He says, what is the place for flexible cystoscopy? You mentioned in your rooms.
Yes. So flexible cystoscopy, I think the thing that, so the place is, there's a couple. What I'd say is it's most commonly performed as a in-office or in-rooms procedure. That's the most common place for flexible cystoscopy, because it's an expensive item of equipment to buy and to maintain and look after. So urologists usually end up purchasing one because they will have a high amount of patients that would benefit from that. So you can do a cystoscopy on a patient for routinely monitoring their bladder cancer to see if they've got recurrences, for example. You can do a cystoscopy on a patient that you know has got some urgency symptoms, and so for example you're considering doing a interstim procedure and you're a bit anxious about the fact that they've had some leukocytes in the urine or UTIs, and you'd like to make sure that they don't have any specific bladder pathology before you take them for more invasive procedures for refractory OAB. So there's various places where it's maybe simpler for the patient and the urologist and more accessible to do a daytime procedure. Flexible cystoscopy is very
painful than a rigid one.
It's much less painful than a rigid cystoscopy. Much less painful, and we use it often in theatre as urologists. So if I, for example, have a patient who's got a suprapubic catheter and they've got significant urethral pathology or strictures, I'll put a flexible scope down a suprapubic tract in theatre. That's another use. You can do flexible cystoscopy on patients that have got urethral diverticulum. It's quite nice because it's like a 0-degree lens. Your flexible cystoscope is completely flush, so your light and your vision comes out of the same spot. So looking for little ostia for patients with urethral diverticuli, it's actually a really nice way to look for the ostia for patients with diverticuli. So there's various applications. The main issue is that most of the hospitals don't keep a flexible cystoscope necessarily in their theatre suites because it's maybe more expensive to maintain and clean. And the urologists are using it in their offices, not in theatre.
Yeah, it's a very useful. I think at British Care when I was working, we got one for the cervix cancer patients, and it was very nice. It's just stood in the office next door to the ward, so that's also a very nice place. There is a question here, Alison. Thanks so much for a wonderful talk, and I think you've highlighted some very important issues, and really, I think given as gynecologists, a good idea is to, you know, the importance of cystoscopy. Dr. Mawunya Kujo Ati has asked, do medical aids fund routine cystoscopy of the gynae procedures in private practice, such as TAH, LVH, and TLH? You know, I have been looking at this myself over the last few years, and unfortunately they don't, because it's considered to be a procedure that is part of the original procedure. So if you want to code for a 1949 during any of those procedures, they won't pay for it. And it does cause some issues, because if you do code for 1949 for some of the medical aids, they will often not pay for some of the other things either, because they'll say, well, that is part of the, so they often not pay for an assistant or something like that. So unfortunately, it's not something that they include, but nonetheless, I still think we should do it. So I don't know if you've got any comment about that, Alison, but that has been my experience, even a TVT.
Even a TVT, your 2548 or whatever the TVT code is, they include the 1949 in that. So you also can't bill a 1949 as a part of a retropubic or other TVT.
There's a question from Paul Bluff about recently a patient mentioned that she has recurrent urinary tract infections for about a year, but since her intrauterine device was removed 2 months ago, this is now much improved. But she remains to have discomfort during micturition. Any explanation or advice?
Current UTIs for a year. So I assume, you know, she's got intrauterine device, so she's premenopausal. So recurrent UTIs in the premenopausal patient are less likely to be kind of hormonally, you know, mediated. You know, you've got your postmenopausal patients who benefit hugely from vaginal estrogen, because that's one of the major issues with that causative effect. So intrauterine device and its link to her recurrent UTIs, I don't necessarily see that. But if she's got persistent dysuria, then, you know, cystoscopy might end up being helpful. Oh, I can't hear you, Steve. Sorry.
Yeah, I know at British Care you said they don't do cystoscopies routinely in patients with recurrent urinary infections, but I do find it to be very useful ultimately to go and have a look. It's very reassuring, especially in your older patients where you don't know what's going on there.
Yeah.
Yeah, and it is quite nice to look for something like interstitial cystitis or all the other multitude of pathologies that you don't have.
Cancer.
Yeah.
Yeah, I've got a lot of patients as well that I'm starting to offer the option of having your hyaluronic acids instilled for recurrent UTI. So there's good evidence that it's actually really beneficial for recurrent UTI, not only for your bladder pain syndrome patients. So I try and then prepare them for the fact that if they've tried their D-manos and their probiotics, and or if it's postmenopausal, their estrogens and macrodantin, if they really want to do prophylaxis, if they've tried all those things, that a cystoscopy with the option of potentially then giving them a dose of hyaluronic acid at the same time would be a next option for management of their recurrent UTIs.
On that point, Alison, can you find the hyaluronic acid, because it was off the market, well, out of the country for some time? Is it back now? Because I've not been able to get it.
Cystostat is still out of stock, not available in the country, but there's an alternative product called Hyacyst, which is from Turkey, from Europe. But it's a 120 milligram dose rather than the 40 milligram of Cystostat. But there's some literature that I was reading up in Europe for recurrent UTIs for Hyacyst, and a lot of the trials are starting to use Hyacyst rather than Cystostat because they see that the patients are needing less maintenance. So the bigger doses are resulting in fewer required doses. The only problem is that Hyacyst is much more expensive than Cystostat.
Okay, because the Cystostat is already about 2,000 Rand per treatment, so the Hyacyst must be even. Okay.
So I've got, so if you can dispense, and if you want to buy through your practice and they offer discount, etc., it's somewhere around about 3,200, 3,500. Now that's without dispensing fee. So at Vincent Pallotti, for example, if a patient wants to buy Hyacyst over the counter as an outpatient, they were looking at more than 4,000 Rand. So it's extremely expensive. But that's the only thing that's available in the country. There's a rep that can bring it in from Johannesburg. What I've found really helpful, what I'm looking at trying to do is, I think giving Hyacyst as the dose that the patient receives in theatre might be really, really helpful. And if they aren't able to necessarily afford Hyacyst as outpatient, then maybe maintenance Cystostat is an alternative, but they've benefited from that 120 milligram dose of Hyacyst in theatre.
Yeah, I give it in theatre as well, or in the hospital as well. That at least comes out of the hospital, payments.
Yeah, and they're coming for a cystoscopy anyway, so it seems to be a beneficial thing to do. But yeah, I think I'm maybe going to use Hyacyst rather than Cystostat for my inpatient treatment.
And okay. Well, that's thanks. That's very good advice, and we can talk a little bit later about that maybe separately. Great, thanks, Pete.
Well, thanks so much, Alison. It's been wonderful having you here again. You certainly have broadened our horizons on this important topic. We've had a beautiful discussion, seen some beautiful pictures, and thanks so much for your time. I see our indefatigable assistant. I'd like to thank her as well. Karen, thank you so much for all your assistance. And Steve, on behalf of the Pelvic Floor Foundation, I'd like to thank you for your sponsorship of this afternoon with Astellas, who've been wonderful in supporting the endeavors of the webinars. So thank you, Astellas. Thank you, Alison. I look forward to seeing you all here at the same time, same place, on a case study-based talk on IUD contraception by Judy Klucher, sponsored by Bayer. Final word from you, Steve.
Thanks, and obviously always thanks to Pete. He's the pivot and the driving force behind these webinars. We thank him for that. So, we look forward to seeing you all next week. Thanks so much for joining, and thanks very much to Alison for a wonderful session. We really enjoyed it.
Thanks, Alison, and safe home.
It's lovely to chat to you both.
Not to thank Steve for the use of his minibar. Thank you, Steve.
As always.
Thank you, both of you. Keep well.
Bye-bye.
Bye.
Bye.